Welcome to this explainer. Look, if you follow women's health, you already know endometriosis is an incredibly painful, chronic condition. And for the longest time, the medical field has literally been desperate for sustainable, long-term treatments. Well, today, we are unpacking a really breakthrough 12-month Phase 3 trial from the American Journal of Obstetrology and Gynecology. It investigates this fascinating hormonal balancing act, one that might just offer a viable, long-term solution for patients who really need it.
Okay, let's dive into this. Here is our roadmap for today. We'll start with the endometriosis dilemma, look at the Phase 3 trial design, measure the pain relief, check in on protecting bone density, and wrap it all up with the bottom line.
All right, Part 1, the endometriosis dilemma, or what is essentially the estrogen catch-22.
To really understand the stakes here, you have to look at the sheer scale of the problem. Endometriosis is a chronic, inflammatory, and estrogen-dependent disease, and it affects roughly 10% of women of reproductive age globally. I mean, think about that. That is a massive portion of the population dealing with this immense systemic burden of pain, fatigue, and quite frequently, infertility.
And one of the most debilitating hurdles these patients face is dysmenorrhea. As you probably know, this isn't just normal cramping. We're talking about severe pelvic pain during menstruation that, when combined with non-menstrual pelvic pain and chronic fatigue, extracts a really heavy physical and emotional toll.
So, here is the absolute core of the medical dilemma, the estrogen catch-22. It's like a giant biological seesaw. On one side, estrogen is the primary driver of endometriotic tissue. It literally fuels the fire. So, treatments naturally aim to lower estrogen to relieve that agonizing pain. But on the flip side, estrogen is absolutely crucial for long-term bone health. If you suppress estrogen too much, patients suffer significant bone mineral density loss. And because of this, these highly effective pain treatments, well, they're strictly limited in how long they can be used. It's incredibly frustrating.
Moving on to Section 2, the Phase 3 trial, and how researchers went about designing the solution.
Now, what's really interesting about the design of this massive Phase 3 trial is the timeline. The placebo-controlled treatment period maps out exactly 12 full months. Pushing a trial to a full year for this condition is actually a major milestone, mostly because earlier protocols almost always hit a brick wall and had to halt at 6 months due to that exact bone density loss we just talked about.
So let's break down the cast of characters here. Nearly 680 premenopausal women were randomized into 3 distinct groups. First up, you have your standard placebo group. Second, a group taking 200 milligrams of Elagolix twice daily alongside what is known as add-back therapy. And third, an Elagolix monotherapy group, meaning they took the drug all by itself for 6 months before blindly switching over to the add-back combination for the rest of the year.
You might be wondering, what exactly is add-back therapy? Well, essentially, you use the Elagolix to lower the estrogen and kill the endometriosis pain. Then, researchers literally add back a highly specific, super low dose of hormones. In this case, precisely 1 milligram of estradiol and 0.5 milligrams of norethindrone acetate. The whole goal is to find that Goldilocks zone, introducing just enough hormones back into the body to protect the bones without waking up the endometriosis pain.
Which brings us to Section 3, measuring pain relief. Did this delicate balancing act actually work?
So the crucial point here is the stark contrast in clinical responders at the 6-month mark. Look at the difference. Only 23.7% of women on the placebo saw meaningful improvement. But for the women on the Elagolix plus add-back therapy, nearly 63% of them met the strict criteria for significant pain reduction. That's a huge jump.
And a trend continues beautifully over time. There is a dramatic gap between the placebo baseline and the treatment results. You see a significant drop in pain scores starting right out of the gate. And importantly, that relief is sustained consistently over the entire 12-month period. No drop-offs, just steady relief.
Section 4, protecting bone density. This is the big reveal.
Did the add-back therapy protect their bones? The data gives us a resounding yes. Patients on the combined therapy exhibited less than a 1% change in bone mineral density at both the 6 and 12-month markers. And this held true across all the anatomic locations they monitored: the lumbar spine, the total hip, the femoral neck, you name it.
To truly appreciate why this is such a game changer, we have to compare it to the Elagolix-only group.
Patients taking the drug without the add-back therapy saw significant bone loss pretty early on. We're talking about a 2.4% loss in the lumbar spine at just 6 months. But for the group using the add-back combination right from the start, that bone loss was highly attenuated, staying safely under that 1% threshold for the entire year. The add-back saw perfectly balanced clinical efficacy with long-term safety.
Finally, Section 5, the bottom line, where we look at safety and future impact.
Now, to maintain our scientific objectivity, we do have to talk about side effects. Overall, adverse events were higher in the treatment group, about 73.8%, compared to 66.8% on the placebo. The most common things people experienced were hot flushes at 17.7%, followed by some nausea and headaches. But, and this is key, the study specifically notes that the rate of severe and serious adverse events didn't meaningfully differ from the placebo group. Plus, study dropouts due to these events were remarkably low. It was generally very well tolerated.
So summarizing the absolute key takeaways from the trial, significant pain reduction was achieved and sustained, the dangerous bone loss was successfully stopped in its tracks, and the whole regimen was well tolerated over a full 12-month period. And this brilliantly illustrates how, after decades of that 6-month treatment limit acting as an impassable brick wall, safe, long-term management of this condition is finally becoming a tangible reality.
Which leaves us with this final vital question to ponder. With these highly promising 12-month results, how will mastering this precise hormonal balancing act reshape the future of chronic pain care for millions of women worldwide? It's definitely a hopeful new frontier for women's health treatments and something we should all be keeping our eyes on. Thank you so much for exploring this remarkable clinical data with us today.